Okay, I'm changing to the patch
Okay.
myself next week. Hello, welcome back to The Bleeding Truth. My name is Sally McNally. I'm the Irish midwife, and today I have a really exciting episode. I've been dying to do this episode. I am with another wise one, and I'm going to introduce you to Dr. Lisa Carbonell. She's board certified in obstetrics and gynecology. She received her medical degree from the University of Puerto Rico and completed residency training at University of Arizona Medical Center. Dr. Carbonell is a member of the American College of Obstetricians and Gynecologists and the American Urogynecologic Society. She's fluent both in English and Spanish, and I am one of the lucky ones who gets to work right alongside Dr. Carbonell, and she is a jewel. We are so lucky to have her, and today she's going to talk to us about hormone replacement therapy and maybe even a little bit about sexual dysfunction. So, Dr. Carbonell, welcome to The Bleeding Truth.
Thank you.
Is there any little thing there that I missed? Is there something you'd like to add?
Yeah, so I think it's important to start off with, like, I do not consider myself the expert in this field. I consider myself a fangirl of the experts, like Dr. Rachel Rubin. I mean, I love listening to her talk, but I do my very, very best to follow the ISWISH guidelines. ISWISH is the International Society for the Study of Women's Sexual Function. It's a group of really smart people that collectively study this topic and, look at the data and answer the questions that we want answered. And so I do my very best to keep up to date with what they recommend and follow their people. So that's where I get my information from. And I also think it's important for us all to understand that, less than 6% of medical doctors get more than 1 hour of education on menopause. So it's so little that your providers are trained in. So all of the education that I have gotten has been post residency, and it has been mainly through this ISWISH society.
And your own interest, of course.
Yes.
You're passionate about this.
Yes.
And your patients are so lucky that you have, studied and educated yourself so well, and you have so many answers for us. Today, we're curious. I mean, we want to know, me and my audience, lots of women out there, and a lot of us are menopausal, a lot of us are perimenopausal, a lot of us are way postmenopausal. But who would you think needs hormone replacement therapy?
Yeah, so that's a big question, and it's basically going to be anybody who has symptoms. And I think, classically we'd always thought of it as the menopausal or the postmenopausal woman, but the perimenopausal woman may be the person that needs it the most. And if you look at, what's happening in that time period, if we were actually looking at hormone levels, like in perimenopause, you're all over the place. You're high, you're low, you're high, you're low. And so that causes all the symptoms. And so I would say definitely in that perimenopausal range. And now, obviously, not all women need hormone replacement therapy. I'm not trying to say that every woman should be put on hormone replacement therapy. I'm just saying that if women have symptoms that are consistent with menopausal symptoms, they should be offered it.
And they're not offered it. That's what I hear all the time, that women go to their obstetrician, their gynecologist, and a lot of women are still told to this day that they're okay, it's normal, that the menopause, they'll get through it and there'll be discomforts. But and I get a lot of young women in their early 40s, even late 30s, asking me, could they be in perimenopause? And they ask for labs? I'm sure you have patients.
Yeah. I mean, the labs is like the one of those interesting topics. I mean, that's a very common question I get. I have patients come in and say, "I think my hormones are not balanced. Can we check levels?" And the book says never to check labs and to only follow symptoms. And then you have the big companies that offer all of these like saliva testing and all these expensive labs that
Yeah.
really at the end of the day are meaningless. But I do feel like there's a fine place in the middle where lab checking can be valuable, and it's important to know what kind of lab you're where you're getting your lab testing done to make sure that the appropriate assays are being done, because when you're doing these saliva tests, there's so many different things, like
Yeah.
they're completely useless tests. Like there's so much that can kind of interfere with those results, so those results can't
Right.
be taken at face value.
Okay.
When do we check labs? Like when is it worth it, and when is it clinically useful? Like when we think of perimenopause, and how we just talked about how things are kind of all over the place. At the end of the day, we're going to look at symptoms and kind of decide whether that's something that needs to be treated. But sometimes, it can be useful for the patient to actually see that they're in perimenopause. So if you're looking at your estrogen levels and your FSH levels, and you're checking at 1 month and they're in what we would consider a premenopausal range, and then you ask them to give you a call back when they're having major mood changes or super brain fog, or really experiencing those hot flushes and night sweats, and we recheck it, and it's going to be estrogen is going to be very low, and FSH is going to be very high. So it's nice to actually see that on paper, and sometimes patients need to see that to see like, hey, I am in perimenopause. But as a provider and with experience, you can kind of tell based on the patient's symptoms. Their menses is changing, their irritability is up.
Yeah.
They have brain fog. They have hot flushes. They have night sweats that are impairing and impacting their sleep. There's
And low libido.
low libido. There's changes in vaginal function, lubrication, arousal. All of those things play into even urinary tract symptoms. Those can all occur with perimenopause. So if you're experiencing those things in and you're still seeing a period or seeing irregularity in your period, you're likely in a perimenopausal time of your life.
And do you think it's a good idea to start a woman, say in her early 40s, on hormone replacement therapy?
1000%. Yeah.
Yeah.
I do. Yeah, I mean, I think it's important to talk about the benefits of hormone replacement therapy, right? Like not only do we see like an improvement in all of the symptoms that we just mentioned, but we also see a decrease in osteoporosis risk that overall and lends itself to a decrease in fracture risk. We see a decrease in risk of dementia. And then on those patients that only need estrogen alone because they don't have a uterus, they see a decrease in colon cancer risk. So there's overall some really great benefits for being on hormone replacement therapy.
Right.
Long term too.
Yeah, I was going to get to that question. How old can we be staying on our hormone replacement therapy?
As old as we want to be. Like there's no
That's
rule.
so
like
great.
Yeah, so as long as we get it started, like we don't need to stop it. And I feel like a lot of patients ask that question, like, when do I have to come off of this? Never. Like you don't have to come off of it ever, because the minute we stop it, all these things are going to come back. And we see that there's good data to show that when you come off of hormone replacement therapy, that bone mineral density that you had gained is gone.
So this is really exciting. You're telling us that she can start her hormone replacement early, and she can stay on it until the end if she wants to.
Yeah, the only reason to come off of it would be if we developed any like absolute contraindications that would force us to come off of it.
Yeah. Tell us about some of them. What would be a contraindication, a reason for not taking it?
So if we look at like the American College of Obstetricians and Gynecologists stated contraindications to hormone replacement therapy. That includes a history of certain types of cancers, specifically breast, endometrial, or estrogen-sensitive cancers, history of blood clots, stroke, heart attack, or active liver disease. Now that's what they're calling absolute contraindication,
Wow.
but there's actually like, and this is very exciting, there's it's important to still have conversations about hormone replacement therapy with these patients, and to look at the whole patient and weigh risk versus benefit. And I think what we're seeing, and what we may see in the future as we get more data and learn more about hormone replacement therapy, that there may be situations where patients have had history of breast cancer and can still be candidates for hormone replacement therapy, because the risk that it actually increases the incidence and or recurrence of breast cancer is potentially lower than we think. So yeah,
that's wonderful
TBD.
news. So when we think of hormone replacement therapy, what are the hormones, Dr. Lisa? What are they?
So we have there's a menu of hormones, and I also think that that's important as a patient going into your provider. If your provider is only telling you that there's one option, that should set up a red flag, because there should be lots of options. We have from my practice, I tend to gravitate more towards the transdermal forms of estrogen, just because they are considered a little safer, in the sense lower risk of DVTs, which are blood clots, but also better profile for sexual function. We see with the transdermals, which is great. And so when we talk about transdermal estrogen, there's the patches, there's transdermal gels, there's a spray, and then there's a fem ring, which is a vaginal ring that goes in the vagina, and then alternatively, we have the oral estrogen, and the reason the oral estrogen doesn't have as good as the transdermals, the sexual function profile we think is better with the transdermals, is because of the sex hormone binding globulin that's created by the liver, which we bypass. We bypass the liver when we absorb.
Okay, I'm changing to the patch myself next week. So going through the skin seems to be a good way to give us this hormone.
Yes.
And we're talking about more than one hormone, right? Here we're talking about estrogen and...
Well, yes. So what I was talking about was just estrogen. So if we have a uterus, it's really important that we take estrogen together with the progesterone, because what happens if we do estrogen alone and you have a uterus is that it can stimulate the lining inside the uterus to grow, and potentially put you at risk for endometrial hyperplasia and endometrial cancer. So to eliminate that risk, we need to have patients on progesterone, and progesterone is given in the safest form of progesterone is a micronized form of progesterone, which is a pill that we take orally. We do have some patch options that contain both estrogen and progesterone. Sadly, a lot of insurance there's often a few insurance coverage issues with the combined patch, or at least that's what I've run into. But if a patient can get both in the patch, it's always convenient to have just like one way to take both medications. Other ways that we can administer the progesterone are vaginally. We can do progesterone vaginally, and we can also use the progestin IUD, specifically the marine IUD, off-label as a form of progesterone as well. Mm-hmm.
That's great.
Yeah, I've used that many times in patients, especially like those perimenopausal patients that have bleeding that's all over the place. We use the marine IUD all the time to really help with bleeding, because most women with it in place either don't have a period or have a very light period. So you're not only solving the bleeding problem, but then you don't have to worry about taking an oral progesterone if we add in estrogen to help with your symptoms.
So great. So wonderful. I get lots of questions about testosterone.
Yep.
Can you tell us a little bit about testosterone? Because isn't that a male hormone? That's what women say. I don't want to grow big muscles. I don't want to
You
be
know,
aggressive.
it's an every person hormone, and it's funny because of the way we measure estrogen, progesterone, and testosterone. The numbers look different, but if we actually made the units the same across the board for estrogen, progesterone, testosterone, we would see we have a lot more testosterone in our system than we do
Oh,
estrogen and progesterone, which is an
yeah.
interesting fun fact. So yes, testosterone is a very important hormone for women, and we do use it to we replace it when we're treating specifically low libido um, and sexual dysfunction disorders. Also, can be used. We can use androgens in the vagina to treat like specific pain related issues. I'm specifically thinking of like vestibulodynia, which is part of the vulva that can cause pain symptoms that we can use androgens, direct application of androgens to that tissue to help with that type of pain. But
So there's all sorts of choices depending on the patient's symptoms and age.
mhm.
And if a lady is larger, would she get a higher dose than a lady who's tiny or smaller
Of testosterone, are we asking?
of
Of
all of the
any,
hormones?
I
Yeah.
mean, not necessarily. So when it comes to testosterone, that is actually one hormone that I definitely make sure that we're checking levels for, because it is a quote unquote male hormone. We want to make sure that we stay in a therapeutic window for women, because if we don't, then we can see those potential virilizing side effects like the deepening of the voice, the enlarging of the clitoris, the acne, the oily skin, the hair growth in places that we don't want it. So
And would that make the lady hypersexual if she
no,
got too much?
not
No.
necessarily. I wouldn't expect that. I wouldn't expect that as a side effect. I would
Okay.
expect those other things as a side effect, but that would only be
Okay.
if they were, beyond the therapeutic window for a woman. So
Okay.
when I'm replacing testosterone, I always like to get a baseline level to see where we're starting, and then assuming that we're in either a low normal level, then we replace, and then we can go up on the dose if when we're checking in we're not we're seeing the levels risen but not as much as we'd like it, and she's noticed an improvement but not where she wants to be. We can tinker with the dose for sure.
Can I stay with the testosterone for a minute?
Yeah.
Because the other midwives and nurse practitioners that I have told about this particular podcast,
Mhm.
they all wanted to know how to dose testosterone, how to administer, and where can we get it?
Yeah, 1000%. So, unfortunately, there is not an FDA approved form of testosterone for women, which is something that I know we're working towards. And I'm optimistic that in the near future we'll have something, but right now we don't. So, what Ishwish recommends, and this is what I do in my practice, is using the FDA approved form of testosterone for men at 1/10 the male dose. So what does that look like? So it's a 1% testosterone gel, and when I prescribe it, it usually requires a phone call to the pharmacist. I send it electronically, but I also call the pharmacist and hold their hand and walk them through how we're going to dispense this. And I also make sure that the patient understands how it's supposed to be administered, because it's off-label use, and we want to make sure that they're using it correctly. So what I do is a 1% testosterone gel. I have the pharmacist give them like anywhere between a 3 to 5 cc syringe. They usually come in either tubes or packets. And so if it's the packet, I just have them open the packet, aspirate the gel contents, and measure out half a cc. So I have them apply half a cc of this 1% testosterone gel to the back of their thigh or their calf daily. And that works out to be about, what is it? I think it's like 300 micrograms of a day of testosterone, which
Okay.
is the 1/10, which equals about 1/10 the dose of what a man would be prescribed.
So it sounds a little bit like math for a lot of women who have brain fog.
Uh-huh.
They might feel like it's a little hard to dose
Yeah,
themselves and stuff.
I have had so I walk them through it. So here's so that's just the general explanation. But sometimes patients come, I can't aspirate it. It's too thick. It's too viscous. So then I have them
Yeah.
pull the tube off at the end of the
Yeah.
syringe and squirt the packet into the tube, and then measure it out that way. I
Okay.
have some patients that are so comfortable with eyeballing half a cc that they'll just stab the packet and squirt out what they know is half a cc, and then just put tape on the
Yes.
packet and call it a day. So once women
Yeah.
start using it, they get used to it. And the nice thing is, because they get so much more with the male dose, their testosterone prescription typically lasts a lot longer than a regular prescription would.
Right.
So
Yeah.
that is a bonus. The other problem that I run into frequently with testosterone prescribing is that insurance often will not cover it, and if they do cover it, they require a prior
Yeah.
authorization. And I always tell the patient this: if your insurance doesn't cover it, just go to goodrx.com, download a coupon that'll bring the price down to something very reasonable. It's usually something around $30-$35, and that'll last them about 10 months. And
Oh,
so
that's really great.
so even if
Yeah.
your insurance doesn't cover it, it's still relatively cheap when we're using this form of testosterone.
Okay. So now we've got a little estrogen patch. We have a little progesterone pill, and now the little bit of testosterone cream.
Mhm.
Is there another hormone that you might prescribe?
Yes, vaginal estrogen.
Yeah.
Vaginal estrogen is so important. I feel like of all of the things that we talk about, that vaginal estrogen is probably the most important, just because of how safe it is, and how good it is, what it does for us. And I think that's important. I think a lot of people think, oh, vaginal estrogen is just meant to help with pain during intercourse or a dry vagina. No, it's not just that. It really helps maintain the biome of the vagina. It helps maintain that vaginal acidity, which helps fight infection. So it reduces the risk of bacterial vaginosis, yeast infection, and more importantly, reduces the risk of urinary tract infections. So it reduces the
Wow.
risk of urinary tract infections by 50%, which is
Wow.
huge. So
Yeah.
I mean, I think on the big scale, like if we looked at it, I think from what I was listening to last time I was listening to Dr. Rachel Rubin talk, she mentioned something along the lines of reducing Medicare costs. So if all Medicare women were on vaginal estrogen, the risk of UTI-related issues and complications would save Medicare like somewhere a little over $2
Wow.
billion. Like
That's
it's
wild.
huge.
Oh my
Yeah,
gosh.
yeah. So
Yeah.
yeah,
And it's relatively cheap,
yeah,
and
yeah. Very
one
cheap.
tube lasts quite a while.
Yeah, so there's three forms that we can use. There's a vaginal pill, a vaginal cream, or a vaginal ring. The ring gets replaced every 3 months. The vaginal pill and the vaginal cream are dosed very similarly. They come with a vaginal insert. You insert them into the vagina. You initially start out nightly for 2 weeks, and then you use either 2 to 3 times a week forever and ever.
Hmm. Forever and ever. I love that.
Forever and ever.
Forever and ever.
And when I say it is safe to use in patients who have had breast
Mhm.
cancer. It is safe to use
Yeah.
in patients who have had cardiovascular. There is literally no reason, no patient that should not be offered vaginal estrogen. And I don't know if you heard, but actually this week, I think on Thursday, there was what was it? An FDA expert panel on menopause and hormone replacement therapy, and kind of like on the forefront of that meeting was removing the black box labeling on
Yes,
estrogen.
I heard that just this morning.
Which
Yeah.
is awesome, because I feel like that creates a barrier on so many
Yeah.
different levels and different situations when providers who don't
Yeah.
know, or patients who don't know, or
Yeah.
patients' partners who see the labeling, even though the
Yes.
patient's been educated, are
Yes.
ambivalent about having them on it. So it's
Right.
incredibly safe, and I'm hopeful that in the near future they'll be removing that black box.
And tell us about that other treatment.
So this is an option for women who either don't want hormone replacement therapy or aren't candidates for hormone replacement therapy. It's a newer medication that's really exciting. We're seeing great results with it, and it's called Veoza. I remember I had my first patient like after the Super Bowl a couple years ago, where it was like advertised, "Call me about it," and I got her started, and she loves it. I have a lot of patients on it. So it works at it's not an antidepressant. It has no hormones, and it works at the thermoregulatory center of the brain. And so it really helps with the hot
Yeah.
flushes and the night sweats if that's the main symptom that you're having.
Okay.
And you either don't want hormones and or are not a candidate, that's a really
Oh,
great option.
and that's called VOZ.
Veoza. Veoza.
Veoza. Okay.
Mhm.
And do they need prior authorization for that
Good
one?
question. So yes, they typically do. I use the specialty pharmacy in Newbury Park, Regency Pharmacy. Regency Pharmacy is fantastic. I use them for all the drugs that I prescribe that require prior authorizations because they take care of it for you. They contact the patient and then they ship it directly to the patient's house.
So let me give you a few examples just for you girls that might be listening at home. Um, I have one patient, she's 68, and she asks me, am I too late to start hormone replacement therapy? I have another lady, friend, she came this morning, we were having a chat, and she said she's had breast cancer and her doctors are saying, no, you shouldn't have hormone replacement therapy. And she's a nurse and she knows they're wrong.
Yeah.
Um, so there's all sorts of confusion out there. And then we get a lot of women who are just almost shy to say, I'm uncomfortable. They feel like it's their life's dharma. They have to suffer. They have to suffer throughout being a teenager, then through childbirth, being a mother, and now here's menopause, just the icing on the cake of being a woman. And it's hard sometimes to convince them that they should maybe try a little hormone replacement. But these are the women we're talking to today, aren't they, Lisa?
Yeah.
What?
Yeah. So, as far as the patient in their 60s, there's kind of this window right now as far as the recommendation for hormone replacement therapy. And again, that's something else that I could see changing in the future, um,
Yeah.
where the recommendation right now is no, not to start hormone replacement therapy in women who are greater than 10 years out from menopause for potential cardiovascular disease risk. Um, but I feel like that may be something that changes in the future. One thing that is safe in that patient is vaginal estrogen. You can start vaginal
Right.
estrogen on your 99-year-old grandmother. It is
Yeah.
fine. It is fine. So that is
Yeah.
something that I would definitely offer any woman at any age vaginal estrogen. I mean, we should be offering it to her mamas who are breastfeeding, who are having vaginal dryness
Oh, yeah.
and pain with
Yeah.
intercourse, because that is just a very natural low estrogen state. And so that is one of the first most common symptoms that women experience when they're breastfeeding. That's called just gestational
Say it louder for the ones in the
yeah, yeah,
back. Yay.
yeah, genitourinary syndrome of lactation. That is, it's a thing, and it's something that we should be offering patients. So yeah, vaginal estrogen is one that I would definitely offer anybody at any age, regardless of risk. Without, there is no risk with the vaginal estrogen.
Okay.
I'm trying to think of what your other. There was
And
a
the
lot
other
of
lady, she has a history of breast
breast
cancer.
cancer. Yeah, so that was kind of something that we touched on in the beginning as to, it's currently considered a contraindication per ACOG, but I think those patients definitely deserve a conversation and deserve, weighing the risks, benefits, and potentially, if they decide that, their mental health, their sex life, their mood, all of that is important to them and worth the potential small risk, then I'm okay with it.
Yeah,
Yeah.
yeah.
I think as providers, we need to ask ourselves what we're afraid of when we're prescribing these things, and really like weigh with the
Perhaps
patient.
it's just that the provider's not up to date on the latest research and evidence. Because some women, they're going to the one doctor for many, many years, and they just feel like embarrassed to even ask for hormone replacement.
I think we were talking a little bit about the stigma of menopause and how women
Yeah,
feel when when we're transitioning into this part of our life, and
yeah,
it is a part of our life that 50% of the population is going to experience. So it's sad
yeah,
to me that it's
yeah.
stigmatized. I mean, we can even see it in medicine, the way things were labeled. Like if you think about genitourinary syndrome of menopause, it used to be called senile vagina, and then after
Oh
that, it was
yes,
called vulvovaginal atrophy. And now,
yes,
yeah, I mean, these are names for medical
yes.
conditions that are kind
Such a
of,
mean thing to
yeah,
say about your vagina. It's
it's totally
atrophied.
awful. Yeah. So now we call it genitourinary syndrome of menopause. So there's definitely
Yeah,
a shift, and we're seeing
yeah,
it across the. I mean, the fact that we're having this conversation
yes,
suggests that menopause is becoming an exciting topic finally.
yes, yes,
And I always tell my patients, the future for menopause is bright. We still don't know enough at all, and
yeah,
there's still a lot to learn, but it is bright, and there's definitely a lot more research going into it because there's a lot more interest in it. So
yes. Well, back home in Ireland, I can remember a time when a woman, when she'd go through menopause, instead of hiding and feeling bad about it, we'd make a party for her, and we'd put her sitting higher than all the other women. And each
awesome.
woman would have to go up and ask her, for a solution to a problem they had. And we thought of her now as the wise one, or
Yeah.
the crone. Now she's wise and has a lot of answers. So perhaps it's a time of our lives that we should celebrate. Uh,
1000%. Yes.
yeah, yeah,
Yeah.
we do have a lot of wisdom as we get old, and if we could just clear the brain fog, we could
Yeah.
share that
Yeah.
wisdom a wee bit.
Yeah.
Um, what else could a woman who's going through menopausal symptoms do? Like, what else would help? Are we, including maybe diet and exercising?
Yeah, it's interesting that one of the symptoms that we see with menopause is weight gain, and I think it's a biological response because there was actually there was a paper put out a couple of years ago. This neuroscience researcher was looking at estrogen receptor density in our brain as we age, and I think when she went into it, she was thinking that we were gonna see it decline with age, but it was actually the opposite. Like the receptor density in the brain, like you know,
Yeah.
increase significantly. Like the brain is trying to latch on to every last molecule
Oh,
of estrogen
oh
that we can
yeah,
get. And I think, when
yeah.
our ovaries shut down, it's kind of a natural biological response for our body to gain weight so that we can have that peripheral estrogen conversion in our fat so that we can get it to our
Oh
brain
yeah,
to help
yeah,
us with that brain fog and that, the potential,
yeah.
dementia that we can see later on down the line. So it's kind of a
Right.
natural biological response. But it's one of those things that we hope can be improved with hormone replacement therapy, but
Yeah,
not always. Sometimes we start hormone replacement therapy, and we don't see that improves.
yeah. Right.
So that is one of the biggest questions I get. What do I do about the weight gain? And short of trying hormone replacement therapy, there isn't a whole lot that's obviously there to say you should try this and this.
Yeah.
There's there's a thought process that maybe with the changes in the gut biome, that could affect our metabolism somehow. So potentially maybe adding in a probiotic tailored to menopause might be, but there's really no great data on that yet.
Yeah.
And then there's all the newer GLP-1 agonist weight loss drugs that are also out there that work, that patients can consider if they want. But otherwise,
Mhm.
eating as clean as you possibly can is a there's
Yeah,
nothing
it's
wrong with
always
that.
good.
Always good. Yeah,
Yeah.
yeah.
What about weightlifting? I've so many
Oh my gosh,
women.
yes, yes. Weightlifting. How could I forget? That's of all of the exercises. Weightlifting is one of the most beneficial things that we can do as we age for our overall well-being, and most importantly for our bone health. It
Yeah.
really helps lower that risk of osteopenia and osteoporosis. So yes.
I have to throw in yoga as well because I'm a yogi,
Yeah.
and I
Yeah.
I know, like, when I started going through my menopause, the yoga really helped.
Yeah, yoga,
It,
Pilates, both of those are going to be
yeah,
great um,
yeah,
for joints, and
yeah,
we didn't mention it, but one of the symptoms of menopause is musculoskeletal syndrome of menopause. We see changes
yes,
in our joints. We see changes in the fluid levels everywhere, in our eyes, in our
yeah,
vagina, in our joints, and we see, our muscle mass actually decreases as we age.
yeah, right.
So all of that can be helped with hormone replacement therapy and exercise, and
Yeah.
specifically weight bearing exercise.
So I have another question about the estrogen cream.
Yeah.
Somebody asked me to ask you, and I want to know now too. Can we put estrogen cream on our
Oh
face?
God.
You knew it was coming.
I mean, there's just no data on it. Like, and we don't know what or how much we're putting on our face. Like, unfortunately, those creams that are advertised online, there's just no regulation behind them. You don't know how much you're getting, and it's your face. Like, until there is something that is FDA approved and proven to show
Yeah.
benefits with good data, I wouldn't recommend it.
Okay.
Yeah.
All right, then I won't. But I do know a few who are putting it
Putting
on their
on.
face.
I mean, there may be benefit. We just don't know. So,
Yeah,
yeah.
right. So libido. If a woman has a low libido and she's has no other menopausal symptoms, how can I help her?
Yeah, I mean, libido is a very complex condition or an issue. And we can see it at any stage in life. We can see it premenopausal, we can see it perimenopausal, we can see it postmenopausal. And it's usually not a black and white issue. I usually, when it comes to libido, like to take a separate appointment just to address libido, because I like to do a deep dive into all of the different things that can affect somebody's libido. And it's usually not something that is just fixed with one thing. Um, I want to know that their desire has in fact decreased, that they remember a time that it was normal and they want to go back to that it bothers them, because that's another thing. Sometimes it doesn't bother them. It's bothering their partner or something like that. And then
Yeah.
we want to address the other things that could impact libido, like pain with intercourse. Are we able to orgasm? Have you had any surgery that could potentially be like vaginal surgery, where there has been a mesh that may have eroded,
Oh yeah.
or scar
Uh-huh.
tissue that is causing pain? Those are
Yeah.
things that you would want to evaluate on a pelvic exam, but all factors that could be affecting libido, because if you're having pain with sex, nobody wants to do something that is causing pain, and it's got this negative feedback loop. So sometimes
Yeah.
it's just a matter of fixing the pain, and then we get back to wanting to do something that feels good.
Right.
If it's, if everything is totally negative and it's just an overall like drop in desire, and there isn't some underlying relationship issue, because that's also a very important factor, like our
Right.
relationship with our partner. Is it healthy? Is it working? If everything is fine, relationship is fine, there's no pain, I've had no surgeries, I don't have any kids sleeping in my bed, or animals, then we talk about adding in medication, and in perimenopause and menopause, testosterone is something that we think about, specifically for the perimenopausal women and the premenopausal women. We have other options in addition to testosterone. There's Vyleesi and Addy, which are two drugs that we use, or can use, to help in those situations. Of those two drugs, my favorite is probably Addy, because it's a pill. It's easy to take. You take it at night, and side effects are weight loss and sleepiness, which usually are not terrible side effects.
And how do they work, and what's in them?
Yeah. So
Because
we
our male friends
mhm.
have their little blue pill,
Yeah.
and they're quite happy
Yeah. Yeah.
with their little blue pill, and
Uh-huh.
they have no qualms about finding it and taking it. That's all great.
Yeah.
But have we got our little
I
blueprint?
mean, I think a lot of the experts would argue that vaginal estrogen is better than Viagra, because not only does it help with all of the things, but it also prevents UTIs, which the little blue pill
Gotcha.
does not. Um,
Yes.
but when
Okay.
it comes to the Addy and the Vyleesi, they both have different mechanisms of action. They work at the level of the brain. Overall, Addy increases dopamine levels and decreases serotonin levels, and Vyleesi increases dopamine levels. And that's basically how they work. The Vyleesi is a little, I haven't had personally, I just haven't had success with it. It's an injectable, and it's meant for women to use when they're wanting to want, which is kind of a weird concept
Yeah.
because they're having trouble
Oh,
wanting. So how do they know to want? But also
okay.
there's a major side effect of nausea, vomiting with the Vyleesi, and the couple patients that I've tried it with have had issues with nausea. And so who wants to have sex when they're nauseous? Um, but Addy has worked really well, and
Yeah.
it works in about 64 to 65% of patients who take it. So I've really loved Addy. And as far as
Great.
the prescribers out there that are interested, it does require a prior authorization, and I usually use a specialty pharmacy called PhilRx, and it's based out of Columbia, Ohio. But if you have an electronic medical record system, you should be able to find that pharmacy, and they take care of everything. They take care of the prior auth. If the insurance doesn't cover it, they offer it to the patient at the cheapest available cost through the
So
company.
we'll attach a link for that at the end of this
Perfect,
podcast.
perfect.
Yeah, great.
Um,
Um, this is great. Such amazing information. You're just a mine of information. It just is so good. I wanted to ask about PCOS.
yeah. Mhm.
Um, a lot of women with PCOS, they want to conceive, they want to have sex.
Mhm.
Do you have any thoughts about hormone replacement with them?
Yeah. So if we're talking about PCOS in the premenopausal world,
Yeah.
this is like the classic example of hormonal imbalance when we're premenopausal. Um, these women tend to have higher levels of estrogen in their system, not enough progesterone, and higher levels of androgens, i.e., testosterone. And so with that comes irregular menses. We can see weight gain. We can see uh, that
Diabetes,
higher risk of diabetes,
hypertension.
yes, hypertension, all the things that come with weight gain for sure. But with the irregular cycles, sometimes fertility planning can be challenging because you can't time intercourse perfectly if you don't know when you're ovulating. So I guess going back to your question about hormone replacement therapy, I mean, yes, I mean the first line of management for PCOS is a form of hormone replacement therapy, i.e., either the birth control pill. Sometimes we'll use the NuvaRing or the patch. Those are kind of the top three forms of combined hormone replacement therapy that we can use to kind of help regulate cycles.
Okay.
And otherwise, I also like to use the Mirena IUD or any progestin IUD because it really helps protect the lining of the endometrium and reduce the risk of endometrial cancer with these patients are definitely at higher risk for if they're not having, especially if they're amenorrheic. So if they're not having periods, which we can see with PCOS, they're definitely at higher risk for developing endometrial hyperplasia and cancer. So protecting the endometrium and putting them on one of these forms of hormone replacement therapy, i.e., the pill, the patch, the NuvaRing, or the progestin IUD,
Cool.
is helpful.
Great. What about women who are not menopausal, they're not PCOS, but they're having trouble having intercourse, pain during intercourse,
Yeah.
uh,
Mhm.
and there doesn't seem to be like a reason to do with their hormones or what
So
do we do?
yeah, so if they're having pain during intercourse, they're premenopausal, they need a physical exam. Like they need somebody with eyeballs on the vulva and the vagina doing a Q-tip test, looking at, all the different parts. One of the more common areas that we can see pain are along the vestibule of the vulva, which if I wish I had a diagram that I could put up for you, but it's basically the same tissue that lines the urethra that goes all the way around to the base of the opening. And so there are different types of vestibulitis, if you will, syndromes that can be treated differently, i.e. with pelvic floor physical therapy or direct hormone application to the areas to treat whatever it is that they're having. But there can be other, like if they've had kids and they have had tears or repairs, there can be scar tissue along the vaginal wall that needs to be addressed either with physical therapy or even surgical removal of the scar, depending on where it is, what it looks like. So I think the takeaway from that is they need a physical exam to take a look at the vulva, the vagina, to make sure that there isn't something
Great.
there that needs to be.
Great. I'm glad you mentioned pelvic floor physiotherapy because I'm a big fan of that. I think that's
too.
really great. Yeah, really
Me
great.
too. Having been through it myself, I knew it.
Yeah. Yeah, that's great. I sometimes come across patients who are menopausal and they're still in love with their significant other, but the libido, of course, maybe is low, um, and they say, well, sometimes I just go through the act just because it makes him happy. Um, and then they say things like, well, use it or lose it. What do you think? What should I say to those women?
Well, I think those women deserve a conversation about testosterone. I think those are definitely the people that may benefit from them. We want to make sure that they're not having pain when they're having intercourse. So if they're not having pain, they're in a good relationship and it's just a drop in desire, then I think testosterone may be very helpful in that situation. I think also making sure that, well, I guess that's a part. I'm just thinking partner wise, like sometimes we think we have a good relationship with our partner, but maybe there is a level of communication that a layer that's missing there. And that's sexual therapy is such a great resource to have in our toolkit. I think a lot of times when we think about therapy, or at least a lot of partners, there can be a little bit of resistance to therapy. So there are workshops out there. I mean, my favorite workshop is through Esther Perel. I don't know if you've heard of her, but she's like the what's the word? She's
the guru
of sexual therapy. Like she's somebody.
What was her name? What's her name again?
Esther Perel.
Esther Perel.
She's just phenomenal. But anyways, she has a couple workshops that's a nice way to remove that third person in the relationship, where you can just work through these workshops with your partner to help with communication and different issues that can affect our sex lives. So that's usually a resource that I recommend to patients. And the workshops are like $120 for hours of sessions. You're not talking to a therapist. It's just led by her through these different exercises that you can do with your partner. So that's a nice resource for sure.
Great. And then of course you can have joy into your old age.
Yes.
Lovely.
Yeah. Oh, also, I mean, I think another thing to consider when we're thinking about patients, that patient that you were specifically talking about, the older woman who feels like she has a good relationship, doesn't have pain, is she orgasming? Like, what's the orgasm like? We can also see a diminution in the orgasm as we age, and that can be either, improved with testosterone or, on physical exam. We need to look at the clitoris. Is there an adhesion over the clitoris? Is there buildup behind the clitoral hood? Do we need to clear that out? Do we need to break those adhesions down so that there is actual stimulation to the clitoris when we're having intercourse and or doing other things to kind of reach that orgasm. So, yeah.
Wow. My mind is like, all this great information. You're so great. Thank you so much. I wonder, is there anything else that we should talk about? I know the big thing that I hear all the time is, oh, I'm not taking hormone replacement. I don't want breast cancer. But now you've dispelled all of that. If we do it right,
Yeah,
um,
I think the reason that there is that connection is all stemmed from the WHI study that was done back in the 90s, and I think that
yeah,
it's certainly worth mentioning that study, because that was kind of like the pivotal moment for hormone replacement therapy, when it went
yeah,
from being prescribed to everyone to like automatically, no hormone replacement therapy.
yeah.
And that study, it was done in the 90s. It was a single dose of medication. It was a synthetic form of oral estrogen and progesterone, and it was given to all women in their 60s plus, so greater than 10 years from menopause. But if you actually look at the data from that study, like break it down, what 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 they saw was when you combine the estrogen and progesterone, um, there was a slight increase in incidence, like a 24% increase in incidence of breast cancer, but the absolute risk was 1 in 1,000. And there was
Huh.
no increase in mortality related to breast cancer, which I think is also important to take away.
Oh,
So
yeah.
none of these women died because of breast cancer.
Okay.
Um, and the other thing is to look at the other arm where it was just estrogen alone. There was no increased risk of breast cancer in the estrogen
Right.
alone group, and there was actually a lot of great benefits in the estrogen alone group,
So,
specifically the decreased risk of colon cancer, which I think is a big one. Yeah,
so if a woman has had a hysterectomy, she doesn't need to take the progesterone,
correct. Yeah, she does not need.
and then her risk of breast cancer would be reduced.
Correct.
Okay, great.
Yeah.
Okay, great. Wow.
Yeah.
Well, I have here something you gave me. It's decreased sexual desire screener.
Oh yeah.
And I love it because
Yeah.
I've used it a
Oh,
few
good.
times,
Good.
and it's just great. I'm just going to read just a couple of the questions for anyone who might be listening to this. This might help you to decide if you want to come and see Dr. Lisa
Oh
Carbonell.
gosh.
In the past, was your level of sexual desire or interest good and satisfying to you? Yes or no? Has there been a decrease in your level of sexual desire or interest? Yes or no? Are you bothered by your decreased level of sexual desire or interest? And would you like your level of sexual desire or interest to increase? I mean, these are such lovely questions for women,
Mhm.
aren't they?
Yeah.
Instead of just, well, this is my lot in life, I'm
Yeah.
growing old and
Yeah.
I'm atrophying,
Okay.
withering away.
Yeah, the other tool that I use with that screener is the female sexual function index. And I really like it, especially when I'm doing testosterone replacement or using Addyi or Vyleesi, because it's kind of give me kind of an objective score. It looks at the different areas of sexual function: desire, arousal, lubrication, orgasm, satisfaction, and pain. And then once we started them on treatment,
Yeah,
and we see them back, 3 to 6 months later, we can have them fill this questionnaire out and then objectively show them, look at the difference. Like, this is an
yeah,
improvement, which is, I think, helpful to both provider and patient. Yeah.
yeah. Wow. Well, I just love this conversation and it's going to help so many women. Is there anything you want to add to any of this?
There's a lot of great resources out there for providers. If you're interested in education in this topic and learning the most up-to-date stuff, I would encourage you to attend the Ishwish. They have an annual clinical meeting, and they also have an annual fall course. The fall course is phenomenal. It's probably, of all of the conferences I've been to out of residency, it's my absolute favorite. I eat it up. It's one of those where I take notes nonstop and I just like consume everything. So I highly recommend those courses. And as far as for patients goes, I mean, there's some really great books out there. My favorite being The New Menopause. Pick Your Menopause Type. Hot and Bothered is another one. And then I think a very well-known one that's great is the Menopause Manifesto. Um, oh, That's
And I'm going to add a little book in there. It's called Yoga for Women Over 50. But thank you so much. That was just so wonderful. And I'm going to share this with everyone. And it's going to help so many people.
Awesome.
So many. Thank you so much. I really appreciate it. And Dr. Lisa Carbonell works at CFH Clinics here in Ventura County and also at Community Memorial Hospital. And you'll be very lucky if you become her patient.
Thank you so much.
I'm really lucky to learn alongside you. Thank you so much.
Oh, thank you. Thanks for having me. Thanks for providing the platform and for having this conversation, because I feel like this is such an important topic.
Well, thank you again. And thanks a million, everybody at home. And hopefully you'll have a listen and share this with all your sisters out there. Good night and good luck. Bye. I'm going to just get my estrogen cream now. Bye. So thanks again for listening. We really appreciate it. And if you like what we're doing, give us a bit of a review on Apple. That would help us so much. And if you come across a subscribe button, press the subscribe button. It doesn't cost you anything.